Assalamu alaikum and very warm welcome to everyone who has joined us for this session. A very exciting and a productive day today for everyone, I hope. And I hope everybody is enjoying the sessions. I am Shehryar and I'll be the moderator for today's session. Before I move on to the session introduction, just a reminder, you can send in your questions and queries through Ask a Question button on your screen, which will be visible on the right side of the screen. So moving on to the talk today, we have is upfront treatment of lymphoma and upfront treatment of DLBCL. So moving on to the talk today we have is on the upfront treatment of DLBCL. The expert we have for this session is none other than Dr. Usman Ahmad. Dr. Usman completed his MBBS from King Edward Medical College, Lahore. He then completed his FRC in pathology from Royal College of Pathologists, UK in 2014. He currently serves as a consultant hematologist at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore, and has a vast experience of managing lymphoma, leukemia, and myeloma patients. Welcome, Dr. Usman, to the session. Dr. Usman, without further ado, since there is shortage of time, I'll just hand over the floor to you. So kindly share your screen and please proceed with the session. Thank you.
Assalamu alaikum. So I'll be talking about upfront treatment of diffuse large B-cell lymphoma in adults. And as you can see that in lymphomas, diffuse large B-cell lymphoma comprises almost 1/3 of the lymphomas. And we're going to talk about subtypes, R-CHOP and its variants, and then certain other issues which comes in diffuse large B-cell lymphoma management like CNS prophylaxis and certain special circumstances like double-hit lymphomas and primary metastatic B-cell lymphoma. So diffuse large B-cell lymphoma is a heterogeneous group of disorders. It is like a bunch of disorders rather than just one disorder with variable outcomes, and they can be differentiated on the basis of their cell of origin, molecular features, immunophenotyping, clinical features, as well as their frequently recurring mutations. So almost 17 years ago, a Hans algorithm was being proposed where they use immunophenotyping to differentiate or subclassify diffuse large B-cell lymphoma into further categories, which was GCB and non-GCB. Actually, the recent classification is a WHO classification which got published in 2016 or further revised in 2016. And there they not only use diffuse large B-cell lymphoma NOS, where they've got subcategory of germinal center B-cell type, which is a GCB type, and activated B-cell type, which is an ABC type. But also they've got other categories as well, like large B-cell lymphoma with IRF4 rearrangement. But the most important feature of 2016 WHO lymphoma classification is that they have highlighted another important category, which was a high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangement. So I think the expression of BCL2 or BCL6 or MYC is something different than the rearrangement, which is the again a genetic rearrangement within the cells. So this is in this diagram, what you can see is that these are different subtypes of diffuse large B-cell lymphoma, but you can see that there's an overlap of high-grade B-cell lymphomas and double expressor and double hit lymphomas with GCB and ABC type. So differentiating these lymphomas into just GCB and ABC type actually does not tell us all the information as far as the immunophenotyping is concerned. And does it change the outcome? Yes. So this is again a Nature paper almost 21 years ago, got published. Small number of patients, but it does tell the important aspect that GCB type patients with diffuse large B-cell lymphoma do better as compared to ABC type. Then again, 15 years afterwards, here they've used different other techniques like gene expression profiling, again differentiating different subtypes of diffuse large B-cell lymphoma, predominantly GCB versus ABC type, but again showing the similar outcome that ABC type, which is the blue line we mentioned in all the graphs, showing poor PFS and overall survival as compared to ABC type. And not only their gene expression is different, their immunophenotyping is different, but also their disease biology is different as well. So in GCB, ABC, and primary metastatic B-cell lymphomas, they originate from various stages of B-cell differentiation and acquire distinct oncogenic abnormalities. and have got different disease biology. So what you can see in GCB type is that predominantly it's an mTOR activation and genomic instability. On the contrary, in ABC type, it's an NF-kappa B pathway which is being activated. And in primary recessive B-cell lymphoma, it's PDL2 and JAK2 pathways are being activated. So different disease biology, and they've got different cell of origin. So now we just move on to that how the treatment is being evolved in diffuse large B-cell lymphoma. So the treatment of CHOP or CHOP-based chemotherapies is being used for almost 50 years now in diffuse large B-cell lymphoma. And first generation was CHOP, and then in second and third generation for the next 15 years till 1985-87, they escalated and added more chemotherapies to the combination. And in 1970s, for the first time, anthracycline was being added from CHOP to CHOP, and what you can see is a survival benefit. It was being published in Cancer. Then, as we talked about, that different escalation regimens are being used pre-rituximab era, where the CHOP-based chemotherapy was being added on further with more intensified chemotherapies. But what you can see here is that the survival, 3-year survival, is almost similar from CHOP to MACOP-B, but the toxicity goes up. As you can see in MACOP-B, the toxicity is around 6%, the toxicity death as compared to CHOP, which is only 1%. So what it tells is that intensification of treatment in the pre-rituximab era did not add further benefit to the CHOP. So CHOP was the winner at that time, and then came the rituximab almost 25 years ago. So this is any GM paper got published in 2002, where first time rituximab was being used in elderly population, and what they've shown is a survival advantage when rituximab was being added to the CHOP regimen, becoming R-CHOP. Then the famous MINT trial, where it's being used, rituximab is being used along with CHOP in a younger patients, and here they use different combinations, including CHOP, CHOP, and MACOP-B, and so on. Again, theme is similar, that patients had rituximab-based chemotherapy. They did reasonably well, and R-CHOP21 was the winner in that as well. So then the question comes up is that can we do better than R-CHOP? Can we recognize high-risk patients? Can we do dose escalations? Transplantation first division is being used, but it was unsuccessful. It did not show any benefit. Dose-dense regimens are being used, like R-CHOP 14. So can they improve the overall outcome? How about maintenance therapy? Can maintenance therapy improve the outcome in diffuse large B-cell lymphoma, as it has shown certain improvements in the treatment in other therapies and cancers? What about novel agents? How they have performed in the treatment of diffuse large B-cell lymphoma, or whether we improve supportive care, and can it improve overall outcomes of diffuse large B-cell lymphoma? So we'll try to answer these questions as we go along. The first question is about dose-dense regimen. So it's a Lancet paper from 2013, where what they have used is they have used R-CHOP21, which is a 3-weekly regimen, which is a standardized regimen, which most of us use, including our center as well. And they actually use R-CHOP 14, where they give R-CHOP every 2 weeks along with GCSF. And what it has shown is it has shown no overall survival or PFS or even free survival benefit. Then the question comes up about dose escalation. So does dose escalation to more intensified treatment has helped in DLBCL or not? So one of the regimen is dose-adjusted APOC with rituximab, which is DA-APOC-R. So here, what they do is they use etoposide, doxorubicin, and vincristine in infusion form for 4 days, and then they give cyclophosphamide on day 5, and prednisone is being given from day 1 to day 5. So this is a paper from JCO, got published a couple of years ago, and what it has shown is that if you look into diffuse large B-cell lymphoma in general, escalation of chemotherapy to DA-APOC-R has not shown any improvement in PFS. So I think to summarize so far, what is being mentioned here is that that various regimens are being used, and CHOP and R-CHOP became the winner. And since then, other regimens are being used, and it has not shown any significant benefit. And on the right side, where I have highlighted, is the is that use of novel agents, bortezomib, ibrutinib, and lenalidomide-based regimens are being used, and the outcomes are there as well, which I would like to share as we go along as well. So before talking about that, let's talk about maintenance therapy. So as we know, maintenance therapy is being used in other B-cell lymphomas and other cancers, like for example, follicular lymphoma. It has shown PFS advantage as well as quality of life improvement as well. Both is being used upfront as well as in relapse setting. Then the question is, does it help here in diffuse large B-cell lymphoma? So it's a E4494 study, again being targeted to the age of 60 to 80 years of age patients, and here they use R-CHOP versus R, and followed by maintenance versus observation. So what they have shown here is, as we can see on the right-hand side, that R-CHOP, when R-CHOP is being used along with maintenance rituximab, it did not show any overall improvement in survival or PFS. But if only CHOP is being used up front, then maintenance rituximab has shown some improvement. But again, the important aspect is that R-CHOP is usually the mainstay of the treatment. It's the main sunrise treatment upfront. So if we are using R-CHOP upfront, then maintenance rituximab does not show any improvement on that as far as the outcomes are concerned. So again, interesting data from MAP-East trial. So what they have done is that they have used subcutaneous rituximab. So just the background that, as we know, that subcutaneous rituximab is being approved and is being used for the last almost 8-9 years in follicular lymphoma, and have shown almost similar outcomes. So the question was that, does subcutaneous rituximab being used upfront in diffuse large B-cell lymphoma, how it performs as compared to IV rituximab with CHOP-based chemotherapy? So what it shows is that in this trial, the overall PFS and overall survival was similar and comparable in both of the arms, suggesting that subcutaneous rituximab can be used in upfront in diffuse large B-cell lymphoma. But again, the important practical aspect is that the first cycle has to be given IV, and if there is no significant or serious adverse reactions or allergic reactions, then it can be used subsequently from cycle 2 onwards. Certainly, it has shown some benefit in the context of decreased chair time, improved patient satisfaction, increased convenience, and reduced patient stay in the hospital. But certainly, it has got some kind of other aspects which you need to look out for, is like injection site reactions and infections at the injection site as well. Now, the other question comes up is about novel agents in diffuse large B-cell lymphoma. So novel agents, as you can, is that they are being used in different B-cell cancers and other cancers, like they are being used in mantle cell lymphoma. Lenalidomide is being used in myelomas. Ibrutinib is being used in CLL. So the question is, does these active agents, when they are being used in diffuse large B-cell lymphoma, have the improved outcome or not? So the first trial which I'm going to share is got published almost 5 years ago, and that is basically R-CHOP was being added with lenalidomide. So lenalidomide is being used in diffuse large B-cell lymphoma for the last almost 10 years, and the famous regimen is being called as R-square regimen. It has shown some efficacy and activity in relapsed refractory setting of diffuse large B-cell lymphoma. But so here they have randomized it, R-CHOP21 with placebo versus R-CHOP21 with lenalidomide. And what they have shown is that, again, R-CHOP versus R-square CHOP, which was lenalidomide added to the R-CHOP, has not shown any significant PFS overall survival benefit. So the next study is a remodel B study where bortezomib was being added. So when I was working in UK, it was our center was one of the centers of where the trial was being run as well, where bortezomib was being given from cycle 2 to cycle 6. And again, the outcome is similar, that it has not shown any survival or PFS advantage. So bortezomib was being out as well in the context of upfront treatment of diffuse large B-cell lymphoma. Then again, another JCO paper being published a couple of years ago, and here they use ibrutinib with R-CHOP versus R-CHOP in upfront treatment of diffuse large B-cell lymphoma, with a similar outcome and similar theme, that overall survival and event-free survival was almost comparable in both of the arms. So actually, so far, what we have come across is that maintenance therapy, as well as dose escalation, as well as using novel agents, have not shown any improvement in the treatment of diffuse large B-cell lymphoma. There are some exceptions to it, which I'm going to talk about subsequently in my talk. But so far, for most of the patients of diffuse large B-cell lymphoma, R-CHOP21 is usually the mainstay of the treatment. So, but there are certain other things which we need to consider. So, what about double hit lymphoma? So, double hit lymphomas, as we talked about in WHO 2016 classification, is being mentioned as a separate entity where FISH analysis with BCL2, CMYC, and BCL6 has to be done. And when we look at the outcomes of, well, before the outcomes, let's talk about their disease biology. As you can see here is that the expression of BCL2 and BCL6 and CMYC can happen in diffuse large B-cell lymphoma, but actually the rearrangements does happen, and when those rearrangements happens, we call them double hit lymphomas, and they do have got a very usually a poor prognostic feature. So this is the paper from Blood being published almost a decade ago, where they have looked at various clinical features of double hit lymphomas, and what you can see is that almost half of the patients are going to have more than one external site. Almost 20-30% of the patients will be having either a CNS relapse or having a high risk of CNS involvement upfront. Almost half of the patients or more are going to have bone marrow involvement. Almost all of them are going to have high LDH, and most of them are going to have stage 3-4 disease as well. So what you can see is that they do present with poor prognostic clinical features as well. How they behave as far as the treatment is concerned. So this is again a Blood paper where they looked at the outcomes of double hit lymphomas using different regimens. So it's a retrospective analysis. So what they have shown is that, in the black line, what you can see is the treatment of double hit lymphomas with R-CHOP, and they have done really, really, really poorly as compared to other intensified regimens like R-hyper-CVAD, DAPOC-R, R-CHORXM, R-AVAC, or other intensive regimens. So again, another paper from JCO almost 4 years ago, similar theme. It is a multi-center analysis of patients with double hit lymphomas who achieve first remission. And you can see again, it's a blue line where the patients who had just R-CHOP have done poorly as compared to those who had more intensified regimens like DAPOC-R, hyper-CVAD, or R-XM, R-IVAC. Then a meta-analysis, which was published in British Journal of Haematology, again, similar theme, that those patients who had in double hit lymphomas who had either EPOC-R or intensive regimens have better median overall survival, which was 21 months versus 31 months. So though in the treatment of diffuse large B-cell lymphoma, upfront is R-CHOP mainly, but in certain situations like double hit lymphomas, we have got significant evidence to say that intensified regimens like DAPOC-R or R-CHORXM, R-AVAC do help. So in our center, we use DAPOC-R with reasonably good results. So then comes the CNS prophylaxis. So diffuse large B-cell lymphoma patients, some of them do have got a high risk of CNS relapse. And in the last 20-30 years, different strategies are being employed to identify those patients who are at high risk, and different strategies are being employed to use certain treatments as a CNS prophylaxis. So I'm not going to go into detail. I'm just going to talk about CNS IPI. So CNS IPI is being based on, it's a retrospective data. It is based on a British Columbia registry data. And what they have done is that they have looked at various risk factors and come up with a CNS IPI scoring system, and which can predict the CNS relapse. And so this is the most popular method to use. So I'm just going to talk about that. So what they've done is that they have used a scoring system for age more than 60 years, high LDH, if a performance status is 2 or more, stage 3 or 4 disease, if someone has got 2 or more external sites, or if someone has got kidney or adrenal involvement. And if somebody is scoring high with scores of 4 to 6, then the 2-year rate of CNS relapse is significantly higher, of 10.2%. These are the ones where we should be using CNS prophylaxis. Now, is it all? So basically, this information is being taken from British Journal of Haematology, which just got published almost 6 months ago. And again, in CNS prophylaxis, as far as CNS prophylaxis is concerned, we don't have any prospective data. It's more about retrospective analysis and registry data to compare with. So these are very good guidelines which I came across. So I'm just going to share those with you as well. So apart from high CNS RPI, what we need to look out for is some certain anatomical sites, like if someone has got three or more involvement of three or more axonal sites, or somebody has got involvement of testicular area or renal involvement or intravascular involvement, or sites like breast and uterus, they would require CNS prophylaxis. But is it all really? So apart from anatomical sites and CNS RPI, what we also do know is that certain categories of diffuse large B-cell lymphoma in the context of cell of origin have got higher risk of CNS relapse as well. And the top of the list is double hit lymphomas. Also, ABC variety has got slightly higher risk of CNS relapse. At the moment, currently, including British Centers of Haematology guidelines, do not suggest to use CNS prophylaxis just on the basis of cell of origin, as the data is still a bit scarce. Certain centers do use CNS prophylaxis for double-hit lymphomas as well. But again, the data is scarce, so the opinion is divided and jury is still out. Then the question comes up is that how are we going to use CNS prophylaxis? So traditionally, intrathecal chemotherapy with methotrexate is being used, but recently in the last 5-6 years, the data has suggested that intravenous methotrexate is preferred way of CNS prophylaxis. So what we can do is, obviously, we need to look out for patients having cardiac or renal function abnormalities where high-dose methotrexate infusion can be toxic and can be difficult to deliver. If someone has got a creatinine clearance of more than 50 mL per minute, then usually high-dose methotrexate can be given safely. In our center, normally we use 2 to 3 cycles of 2.5 to 3 gram per meter square of methotrexate. You can use it intercalated, like every 2 or between the cycle, high-dose methotrexate can be used, or it can be given later after completing the R-CHOP chemotherapy as well, depending upon how the high risk is and how quickly you can deliver it in your center without affecting the duration of R-CHOP chemotherapy. So there are other diffuse large B-cell lymphoma variants as well, where the treatment is different. I'm going to briefly touch on certain lymphomas here. So primary CNS lymphoma is a completely different entity, where you would be using CNS-penetrated drugs like high-dose methotrexate, cytarabine, thiotepa, and so on, to treat these kind of lymphomas. In testicular lymphoma, what you really need to do is, apart from giving R-CHOP, you would use radiotherapy and intensified your CNS prophylaxis with high-dose methotrexate as well as intrathecal methotrexate as well. Ocular lymphomas are usually being treated like CNS lymphomas. In DLBCLs having renal or adrenal involvement would require CNS prophylaxis. If it's an HIV-associated diffuse large B-cell lymphoma, you would use R-CHOP along with aggressive treatment of HIV as well. If it's other HIV-related lymphoma, obviously the treatment is going to be different depending upon the type of the lymphoma. I've got a few slides for primary mediastinal B-cell lymphoma, and the reason is that actually it's a different entity. So it originates from thymic B cells. It has got a characteristic histology which resembles more with Hodgkin's lymphoma. It does have got a pan B-cell antigens like CD19, CD20, and CD22, but also it also expresses CD23 and CD45, which actually helps in differentiating it from the traditional diffuse large B-cell lymphoma. So a different disease entity which has got slightly different treatment as well. I've got just one slide to share here, where so it's a phase 2 trial, and what happens is that primary mediastinal B-cell lymphoma is more common in young females, where they present with a huge mediastinal mass, and the traditional treatment was R-CHOP chemotherapy followed by radiotherapy to the chest. And what you can imagine is that radiotherapy to the chest, especially to the young females, can have a lot of sequelae and after effects, including risk of secondary malignancies and breast cancer. And obviously, it's going to be cardiotoxic as well. So in this phase 2 trial, what they have shown is that they have used DAPOC-R, and with very good outcomes, more than 90% event-free survival and overall survival. And they omitted radiotherapy. So in our center, we are using DAPOC-R for primary mediastinal B-cell lymphomas as well. and you are usually not employing radiotherapy. Now we are moving towards the end of our talk, really. So this is again a paper in Blood published a couple of years ago, which I would like to share. So we have not talked about imaging really. So as we know that PET scan is being used in diffuse large B-cell lymphoma nowadays for staging purposes. So here, and in Hodgkin's lymphoma, not only this PET is being used for staging purposes, but PET-directed therapy is kind of quite well established as well. So here what they've done is that they have used non-bulky stage 1 and 2 patients with diffuse large B-cell lymphoma, and they've done PET scan after 3 cycles. And so it had another arm as well, but I'm just going to focus on this arm. So those patients who are PET negative, they just gave 1 additional cycle of R-CHOP without any radiotherapy. And additionally, we were using radiotherapy in stage 1 and 2 as well, along with R-CHOP chemotherapy. And look at the outcome. So almost again 90% overall survival and PFS for these patients who were PET negative after 3 cycles, and radiotherapy was not being used. So to summarize, what I would say is that in diffuse large B-cell lymphoma, cell of origin confers prognosis, and though still at the moment it's less well established, but likely we would be having different treatment strategies in future. R-CHOP is still the mainstay of treatment for major diffuse large B-cell lymphoma patients, with certain exceptions. R-CHOP subcut can be used from cycle 2 onwards for ease of delivery and in less time. Certain subtypes of diffuse large B-cell lymphoma, like double-hit lymphomas, primary medicinal B-cell lymphomas, would need different treatment strategies. PET-directed therapy is maybe around the corner, and it's slowly being established, I think, as we speak. So I think that concludes our talk, and thank you.
Thank you, Dr. Usman, for a very informative, very insightful, and a very comprehensive session on upfront treatment of DLBCL. And thank you for sparing time for this session. Before we move on, we have a couple of questions which we have received from our audiences. So the first question, here it goes. In your opinion, what is the role of PET in DLBCL? Is it diagnostic, prognostic, and does it affect the treatment decision for you?
Okay, so PET is being used in staging of diffuse large B-cell lymphoma and is being preferred. The only difference is that it is for bone marrows, it is not very sensitive as in Hodgkin's lymphoma. So the current guidance is that we would use PET scan as we use in our center as well for staging purposes, but we would use bone marrow biopsies in those patients where bone marrow involvement would change the treatment strategy, like for example, stage 1 or stage 2 diffuse large B-cell lymphoma. As far as the treatment strategies are concerned, as I mentioned in my last couple of slides, that at the moment, treatment PET is being used initially upfront and is being used at the end to see whether the patient has got a remission or not. But the treatment-directed therapy is not very well established, apart from just one paper which I've just shared, where if somebody's PET negative after 3 cycles of R-CHOP chemotherapy who has got non-bulky stage 1 and 2 diffuse large B-cell lymphoma, then we can get away with just giving 1 more cycle of R-CHOP.
Thank you, Dr. Usman. Another question, is it mandatory to find cell origin like GCB or non-GCB and markers for double-hit lymphoma? And is this practice followed here in Pakistan?
Okay, so it's a difficult question, really. So I think so the last part is difficult about Pakistan. So the cell of origin is important because certain, as I mentioned in my talk as well, that certain diffuse large B-cell lymphomas like double-hit lymphomas, primary medicinal B-cell lymphomas would be having a different treatment. So it is important, and also to find double-hit lymphomas, we need to do the FISH studies for BCL2, BCL6, and CMYC. In Pakistan, it is an expensive process, and it's not happening in all the centers. Certainly, I think it's difficult for it to be done for all the patients at the moment, again, because of the expenditure issue. In our center at Shehryar Khalid Hospital, just in the last almost 8-9 months, FISH analysis for BCL2, BCL6, and CMYC is being established, and we are using it. But again, I must say we are not using it for every patient. But most of the international standards and most of the international centers, both in Europe, UK, and USA, would use FISH analysis for all the diffuse large B-cell lymphomas to identify those high risk or double hit lymphomas where the treatment is going to be different. So I think it's all about how the treatment and how the services establishes in a country and in a center. It took us a bit of time to establish in our center as well, and but again there are financial constraints. But I'm hoping that as we go along, we would be using in all of our patients.
Thank you, Dr. Usman. Last question we have received. So we discussed in previous session as well the importance of R-CHOP. Can you please share what approach you apply when the patient cannot afford R? So what is your take on that?
Okay, so I think I've got a specific view on it, and that is a personal view. The personal view is that in any setup, including the most sophisticated setup versus the most underdeveloped setup, it's all about using the resources in the best way and giving the best shot for the patient. So it's all about what you have and how to use it. So I'll give you an example here. So basically, if the rituximab is not there, CHOP is being used. So the historical data is that adding rituximab almost gave 10 to 15% benefit in the context of overall survival and PFS. So if someone has got stage 2 or stage 3 disease where with R-CHOP, you're going to have a PFS advantage of around for 60% of your patients. If you're not using rituximab, you may be curing or maybe treating only 45%, 50% of your patients. So you're not doing bad. So my suggestion and would be that if rituximab is not there, then CHOP can be used, and still quite a few number of patients would get benefit and potentially would be cured with that. But again, it's not a standard strategy. It's not ideal, but it's all about using your resources in the best way and whatever you have. There's one more thing I need to mention as well, which again, I shared the slide where they used CHOP with maintenance rituximab and R-CHOP with maintenance rituximab. So what they have shown is that if you're using R-CHOP after maintenance rituximab, does not help. But if you use CHOP and then the patient, say, for example, can't have a money, but they may get some more money out later on down the line, then again, it's not a usual practice. It's not in the guidelines, but we have got some data to say that you can use maintenance strategy where patient can get more money as they go along, and then may be able to use rituximab, and they may get some more benefit out of it. So I think the bottom line is, again, use the resources, whatever you have, in your best way, and hopefully you would do good for your patients. Again, even in the most privileged setup, they may not have all the novel agents all the time.
Thank you, Dr. Usman. A very nice message that wherever you are, use the best resources you possibly can to deliver better outcomes to your patients. This is basically the end of our talk on upfront treatment of DLBCL. Thank you very much for a very comprehensive, very insightful talk, and thank you for sparing your time for this session. I hope and I hope that people here really benefited from your talk. So moving on, thank you, Dr. Usman, for your talk. Thank you for being with us. So moving on, I will be moving on to the next session, the next part of this session. We have with us the next talk we have for today is on nucleic acid testing for preventing transfusion transmitted infections. And we welcome our speaker for this session, Dr. Sabeen Khurshid Zaidi. Before moving on, I will be introducing Dr. Sabeen. Dr. Sabeen did her clinical fellowship in virology from the Sheffield Teaching Hospital, UK, and then completed her FRC pathology from UK. She currently serves as Associate Professor for Pathology at Karachi Institute of Medical Sciences. Without further ado, I would like to invite Dr. Sabeen to continue her talk and to start her talk on nucleic acid testing for preventing transfusion transmitted infections. So over to you, Dr. Sabeen.
Can you hear me now?
Yes, Dr. Sabeen, you are audible, you are clear. Please carry on.
Can you see my screen? I've shared it.
Yes, your screen is visible.
Okay, fine. Sorry for that. Anyway, so I was not audible previously, so let me just begin again. So first of all, I'm extremely grateful to be speaking on such an important topic in this August forum, and I have no disclosure to report. So today's presentation will be discussing blood safety and transfusion transmitted infections, relative roles of nucleic acid testing, specific infections, why certain tests are used, and obviously the relationship of NAT in the detection in relationship to the virus concentration, and various scenarios and discrepancies. We'll be discussing those. And so basically, ladies and gentlemen, we know that blood is a biological product, and it has to be safe, especially free of infections, because we need to have almost a zero risk for transmitting these infections via blood transfusion. But that's not always possible. It depends on many factors, the prevalence of the disease in that particular area, plus the screening tests that are used. So we'll be discussing those. So what is actually a transfusion transmitted infection? The recipient had evidence of infection post-transfusion, and there was no evidence of infection prior to transfusion, and no evidence of an alternative source of infection, and at least one component received by the infected recipient was shown to contain the agent of the infection. So you must have all heard as clinicians and technologists about the window period. What is the window period? So from a technical viewpoint, the window period is the period between the moment somebody has acquired that viral infection and the time at which the presence of the virus can first be identified in the blood, either by testing for antibodies against that virus or for antigens or for the nucleic acid, the DNA or the RNA. So while using the routine serological methods, the window period, as I've shown on this slide, for HIV is about 22 days with a range of 6 to 38 days. For hepatitis B is 59 days with a range of 37 to 87 days. And for HCV, quite long, for 82 days with a range of 54 to 194 days. So here you find out that it's really important that if you use a test that is sensitive enough to actually shorten this window period, the risk of transfusion transmitted infection would definitely decrease. It wouldn't go to zero, but it would definitely decrease. So what are the major sources of transfusion transmission risks? So one is obviously the window period donation. And then another is actually, which may be quite rare, is viral variants not detected by the current assays. And then obviously lab testing errors, which can be prevented. So what is the failure of testing for known agents? So basically, what happens is that if you donate blood during the window period and you've not detected the particular pathogen, there is a chance of it being infecting the recipient. Now, this doesn't entirely depend on the window period. It also depends on many other factors like the immune status of the individual, the viral load of the particular pathogen in that product. So there are other factors that come into play, but window period is very important. It's something that can be shortened and the risk can be definitely, sort of diminished. So what have been the testing advances over the years in terms of transfusion safety for shortening the window period? So there are there are tests in the beginning when you go back. Let's start off from the AIDS epidemic. So before that, there was hepatitis B in the 1960s. The Australia antigen was detected, and they started screening for hepatitis B surface antigen. Then there was an entity known as non-A and non-B hepatitis, and then it came out to be hepatitis C in the 1980s. And then the AIDS epidemic. So if you have a look at the evolution of the tests, there was serology, and then antigen tests, and then finally nucleic acid detection. So by addition of these tests, generally, the standard is that we use both serology and nucleic acid testing, and to reduce this particular window period, and also in terms of cost effectiveness as well. So what is the complexity of ensuring blood safety? It's quite a complex procedure, as you can see. It is a multi-pronged approach, which begins with donor selection, the screening questionnaire. Again, there are various questionnaires which are actually designed according to the prevalence of infection in a particular area, and also according to the, of differing donors. For example, since the COVID pandemic, in the USA and UK, they have limited the donor deferral time for high-risk donors or sexual contacts from 12 months to 3 months for HIV and hepatitis B, basically because they want to, because of the convalescent plasma issue and because of the blood banking logistics. So, but that is because they're testing with NAT mainly. That's why they've shorten the deferral time. So it's the donor selection, and then obviously serology and NAT, pathogen reduction modalities. These are actually using UV light or riboflavin. They're not, to my knowledge, they're not being practiced in our part of the world, but these were done for Ebola, convalescent plasma from Ebola, people who had recovered from Ebola, because convalescent plasma was also used for Ebola, although it was not that effective. And then obviously all these processes require quality assurance with audit, clinical audit, and the blood transfusion committees playing their roles, the processing, quality, and it's very important tracking and surveillance of all of the adverse events, including the TTIs, obviously. And there are various systems in place in countries, like there's an independent organization by the names of Serious Hazards of Transfusion in UK, which in collaboration with the MHRA actually monitors all these adverse events, including TTIs. And then the NHSN in USA, and obviously we've got a program in the last decade, the Safe Blood Transfusion Program, that has done and hopefully will be doing a lot of work on this. So viral safety in blood transfusion has basically improved, as I discussed, due to improved donor selection, sensitive screening assays, and obviously these newer modalities which have come into play. So what are these TTIs? So the TTIs, the common ones in our part of the world are hepatitis, and there are others. There's a lot of names here of parasites and Babesia and Chagas. These are some of the ones that are rare, and we generally don't screen for these in Pakistan. Then there's CJD or prion disease, the variant form, and usually it's the risk assessment is done in UK and US for these. And then HTLV, there was a study, very good study over the last decade from AFIT by Niazi et al., in which they screened blood donors for HTLV. And I think the prevalence frequency was around 0.19%, if I'm not wrong. And then obviously the common blood-borne virus infections and malaria in endemic areas. So this is really important. And then the emerging viral infections like Zika, chikungunya, and even, from a theoretical point of view, although I'll be discussing about SARS-CoV-2. So what is the current scenario, or what is the data about common transmissible blood-borne viral infections in Pakistan? So this is a very good systematic review, which was published in the Journal of Blood Medicine last year. So these authors, they actually reviewed 33 articles which met their criteria, and that excluded articles not related to transfusion diseases other than TTIs or chronic transfusion-dependent population. They excluded those. And when they analyzed these studies, they found a cumulative frequency of hepatitis B of 2.4%, 2.04%, of HCV 2.44%, slightly higher, of HIV 0.038%, syphilis 1.1%, and malaria 0.1%. And the frequency of co-infections among the blood donors varied from 0.009 to 0.35. Now, the data that they actually analyzed, there was a lot of variation in the screening technologies. Many of the tests, the blood banks had been using RDTs or ELISAs. Some were using CLIA, and a very few were doing that. So basically, what they found, there was a significant difference in the frequency of HPV and HCV in voluntary non-numerated donors as compared to replacement donors. So when we talk of HIV, although this figure appears to be quite low, but when we look in the past year, when we look at the interior Sindh outbreak of HIV, we realize that it's actually the tip of the iceberg. And it's really a hazard that has to be mitigated, especially for transfusion in these high prevalence areas as well. So what is not detected by testing, serology, or even NAT? And that's the residual risk. Although this is a very lay term that I'm, presenting the lay term definition. The actual calculation of the residual risk actually depends on the incidence of that viral infection and obviously the screening test that is used, and it's calculated according to various models. So the estimated risk that the donation entering the blood supply is potentially infection, but is not detected because the donation is made during the window period. And basically, in this bottom diagram, it's taken from Short UK, and they've actually shown a timeline from 1972 to 2018, that what is the reduction, what is the impact of NAT reducing this particular window period. For HCV, for example, it's really almost 70% reduction, right? So it really makes a difference, especially for a country like ours, which is high. I mean, sort of we've got more than about, I think, 5% seroprevalence in the general population, 5 to 7%. And then for HIV, it's reduced to 9 days, for HPV to 10 days. So this actually just shows the UK experience of how various tests were introduced and then the impact on the window period. So this is US data, and US also implemented in the late 90s NAT testing, and then they added hepatitis B NAT as well later on. And they've been doing NAT testing for West Nile because they've got a problem there. With West Nile, they usually do pooled testing or targeted individual testing when there's epidemics. So you can see the impact that for whole blood, the risk has reduced to 1 in 1 million, hepatitis C 1 in 1.2 million, and so-and-so HIV 1 into 1.5 million. And this is all because of the introduction of NAT testing. And down here, when we talk of solvent detergent-derived plasma products, there's a role of NAT testing there for non-enveloped viruses like hepatitis A and parvovirus, which are known to cause chronic infections in immunocompromised or aplastic crisis, and hepatitis E, which can develop chronic infection leading to cirrhosis in the immunosuppressed, especially genotype 3, which is more prevalent in Europe. These are not fully inactivated by the solvent detergent treated process. So these, prior to this process, they're screened by NAT for these viruses, hepatitis A, parvovirus, and hepatitis E. So what about SARS-CoV-2? In the beginning, obviously, most of the centers were actually, some of them were even testing blood. And there has been reported that there's a brief period of viremia, but I believe that they haven't really cultured viable virus from there. And so far, there have not been any cases of transfusion transmitted infection from SARS-CoV-2. And usually, as per the FDA, US FDA guideline, if somebody has got SARS-CoV-2 infection and if they're otherwise healthy, so if they've been deferred for a period of 14 days, they may give a donation. And similarly, when we talk of vaccines, because we've started vaccination now, so far there isn't really any risk or any deferral of donors. This is in association with this from the American Association of Blood Banks and the FDA, that individuals who received a non-replicating, inactivated, or messenger RNA-based COVID-19 vaccine can donate blood if provided they fulfill the other criteria. However, if somebody is donating this for convalescent plasma for SARS-CoV-2 for COVID in a clinical trial. So one needs, the guideline is a bit different, that if that person has recovered from COVID and obviously they've passed more than 14 days from the last resolution of symptoms, and the vaccine was given after COVID. So, and they are within 6 months of the 14-day period, they can still donate. But however, the reason for this of actually deferring people who have had the vaccine for convalescent plasma is the immunological issue, that it may interfere with the immunity, and that's why so far we don't have enough data on that, so they are deferred. So basically, if you have a look at this timeline, UK introduced hepatitis E RNA NAT testing in 2016. when I was there. And this was a time, basically, they started it for immunosuppressed recipients. And then they shifted on to testing for all. And the reason behind that was that the type of genotype that is prevalent in UK, I don't know about whether there have been any chronic HEV infections reported in our immunosuppressed cohorts in Pakistan. I don't know about that data, but we do know that for genotype 3, it does cause chronic infection in the immunosuppressed cohort, which can lead to cirrhosis. And that's why this screening was commenced. So over this period of 4 years, they screened over 1,300 HEV RNA containing blood donations were removed from the clinical supply. And out of these, there was, I think, 2 of them were missed, and one developed, one patient was an immunosuppressed patient, and they developed chronic HEV infection, were treated. So this is the significance of this, and this actually opens an arena for us to actually investigate, because we are a highly endemic country for HEV. And have there been any studies for studying whether types 1 and 2 can cause this chronic infection in our immunosuppressed cohort? So when we're talking about, for any assay, specifically for a molecular assay, I really refrain from using the word negative. The reason is that, for example, if you use an assay with 95% lower detection limit of 20 IU per ml, we would likely miss a viral load below that. For example, if it's 10 IU per ml, right? So, for example, a platelet unit contains around 180 ml of plasma. And if a viral load of 10 international unit per ml is not detected by the assay, a viral dose of 1800 international unit would go to the recipient. And obviously, there could be a possibility of them getting the infection. So it's important to know this important fact, the sensitivity of the assay counts. So coming on to NAT, most of us over here are hematologists, and they already know what that is, but just a bit of a recap. It's a generic term that includes a number of different technologies, which may be PCR or isothermal TMA, NASBA, LCR, but nowadays 2 main ones are TMA and PCR, real-time PCR are used. And most of the, NAT has progressed tremendously to these automated, semi-automated, fully automated these platforms, which are modular. And, for cost effectiveness, this pool testing, and some centers have shifted on to individual donor testing, which we'll be discussing. And obviously, NAT testing has played a role in detecting occult hepatitis B, which I'll discuss later on. So there are 2 main types of, there is the mini pool NAT or the individual donation NAT. For logistical reasons and costs, this mini pool NAT is good for resource limited settings. But we need to keep in mind, the larger the pool, the less the sensitivity. So usually in most of our studies that I've read, they've used pools of 6. And if a positive result is obtained on a pool from a mini pool, further testing is performed to establish which donation was the source of the positive result, and confirmatory testing as per the algorithm of the particular blood bank is carried out, and the donor, that donation is obviously excluded, and the donor is recalled and counseled and linked to care. And then there is individual NAT. This actually increases the sensitivity, but it's more expensive. And IDNAT results in a higher assay sensitivity. As an example, it has been estimated that the time period between the infectivity of a blood sample, which we estimate usually as 1 viral copy per 20 ml, and it's detected by NAT, can be shortened from 9 to 5.6 days to HIV, and from 7.4 to 4.9 days for HCV, by replacing the mini pool NAT. But there are obviously cost issues and, of adopting this, in especially resource limited settings. If you can afford it, it can be done, but obviously. So these are actually I'm sorry, this is a busy slide and maybe some of you may not be able to discern it, but let me just give you an overview of it. These are some of the FDA approved triplex assays or the multiplex assays. When you're selecting these, you need to know whether the assay includes, does it detect it in all in one, or do you need to do discriminatory testing, which means that further testing and the cost and the platform, everything else you need to. So there are assays which are based on PCR, on TMA, and these are the FDA approved. So they detect all 3 HIV, and some of them even detect, differentiate between HIV-1 and HIV-2, some do not. And we know that there are 2 main clades of HIV, main and outlier. So we don't want an assay to miss that. So let's get to some Pakistani data. So this was a study that was carried out in Liaquat National Laboratory Blood Bank and multiplex real-time PCR for transfusion transmitted infections in southern Pakistan. And basically, they screened 16,957 donors, and all the 16,002 seronegative donors were tested. Excuse me. Were tested. So 2,767 test pools were analyzed, which yielded 21 reactive mini pool. And on pool resolution, 7 mini pools were natural non-reactive on the individual donor samples. So these pools were labeled as false positive. So the NAT yield of basically, as you can see, was 10 donors for HBV DNA, that is 1 per 1,600, and 4 for HCV RNA, that is 1 per 4,000. None were HIV positive. Then this other study that was carried out in a private blood bank in Islamabad, they basically also did the mini pool testing with pools of 6 on the seronegative donors. Now, excuse me. So what they did was that nucleic acid testing on the seronegative sample showed an overall net yield of 1 in 2,285 with 0.03% donors that tested positive for hepatitis B DNA, making the HPV net yield of 1 in 2,971, while only 3, that is 0.01%, were positive for HCV RNA. Sorry, that's RNA, making HCV net yield 1 in 9,904, and no donor was found positive for HIV by NAT testing. And then this is a study which was carried out about 5 years ago at Armed Forces Institute of Transfusion, in which they actually screened 56,772 donors. And they then tested the seronegative ones for NAT, which was also mini pool NAT for hepatitis B, C, and HIV. On resolution of the pools, they found out that 62 donors, 0.11%, were found reactive initially, and confirmatory testing involved repeat individual testing from AFIP on centrifuge samples, and serological tests confirmed 27 reactive donors, 0.05%, with an overall net yield of 1 in 2,016 donors. Now, the overall false positive rate of NAT in this study for the total 54,438 donations tested was 0.06%, with a clinical specificity of 99.94%, 95% confidence interval. A total of 23 donors were found to be reactive for HBV DNA. Net yield was 1 in 2,367, and 4 donors were reactive for HCV RNA with a yield of 1 in 13,609. There was no case of HIV which was detected by NAT during this study. So it was a fairly robust study, and you can see that there's an algorithm that they used. And if you just go through the algorithm, when they screened the seronegative donors in pools of 6, and the initial reactive ones were then tested by individual net for resolution of the pool and discriminatory testing. The ones that were non-reactive here, they were released as blood products. The ones that were reactive, there was donor recall, notification, and counseling. And the donor recall, if it was successful, that was a fresh NAT sample. If on the fresh NAT sample it was reactive, then again they were followed up with these particular tests linked to care. And if there was not reactive on ID NAT at least twice, there was centrifugation of high volume of donor sample and repeat NAT. And if they've so this is basically how it's usually done. So the blood banks, whatever testing algorithm they it has to be robust and to confirm and to dish out the false positives. So this is really important. So let's talk about HIV, the relative timing of infection for HIV. We know that basically in HIV, when one gets acute HIV infection, the first marker to come is actually HIV RNA, right? And then it's followed by the P24 antigen and then the antibody. So the third generation ELISAs were able to pick up IgM as well. So they sort of shortened the window period. And then there was the fourth generation ELISA with the P24 antigen. And so, sorry, I've gone ahead. So for HIV, currently the infectious window period is 5 to 10 days prior to RNA detection. And when we talk of the window period in terms of HIV, there's an eclipse phase in which there is local replication of the HIV, and it's not causing viremia, or it's causing viremia and blips. So at that time, even the most sensitive net may not be able to pick up HIV. That's usually the first week of infection, around 9 days of infection. After that, RNA will definitely pick it up, an acute infection. And so this is how HIV is actually, and how RNA testing can pick up people with acute HIV, right? For HCV, the relative timing of detection of nucleic acids. So for acute HCV, obviously, seroconversion takes time. So roughly 4 to 6 weeks. And the first marker, again, is RNA, right? And for HCV, currently 3 to 5 days infectious window period prior to RNA detection. And this is obviously being, it's important to know that certain, viremia may also fluctuate in hepatitis C. So you can also miss that. And that's why whenever we get an anti-HCV reactive person or individual, and they are negative even by viral load, we usually repeat it because they may have blips, right? And then for HIV, so HIV and hepatitis C are both chronic infections. And so antibody is the most important screening test, obviously, to pick it up in the chronic phase. That is against anti-HIV 1 and 2. And but during acute infection, P24 antigen has a role as well as RNA testing. So once it appears, antibody remains positive, RNA levels may be lowered by antibodies or treatment. RNA testing provides incremental detection for early infection. And then there is a cohort of patients, I don't know about data in Pakistan, but we did have data in elite controllers. These are the patients that basically, they have very low viral loads and sometimes undetectable. And they've got some genetic, makeup, which actually, maybe they've got a defective receptor, CCXCR4, and they actually sort of control the HIV. But whether or not they are transmissible is very rare. So chronic infection with hepatitis C may resolve in about 20% of the cases who get it, but most of them go into chronicity, as you know. And antibody is the primary screen. Once it appears, it will remain positive. RNA is of benefit to detect early infection prior to the appearance of the antibody in the window period. Now, there's one thing more that I want to mention, but although it may not be as relevant to transfusion medicine, people who are infected with HIV, especially those who are not suppressed on treatment in our part of the world, they may not mount an HCV antibody response. So the only marker of HCV infection in these particular individuals would be HCV RNA. So RNA is of benefit to detect early infection, and also this group of HIV-infected patients. RNA may become undetectable due to spontaneous resolution of infection or treatment. So that's important. So chronic infections in general, viral infections, antibody is the most important screen. NAT is added to actually decrease the residual risk and to provide incremental benefit. So when both tests are used, so if these are reactive on serology, it's the serology yield, and if NAT positive, that is known as the NAT yield. So what about hepatitis B? So hepatitis B is a little, more complicated than HIV and HCV serology, as you can see. So when somebody develops, so first of all, have a look at the epidemiology in adults. So most of the adults are actually going to clear hepatitis B, right? They are going to develop anti-HBs, and the only marker they may have is actually anti-HBC total, with may or may not have anti-HBs. It may dwindle down to below the detection limit of the assay. So when you get acute hepatitis B, the first marker to appear is actually hepatitis B DNA. followed by hepatitis B surface antigen, and then the IgM, which there is a window. There may be a window in which hepatitis B comes down, and the only marker is IgM, especially in fulminant hepatitis, because the antibodies is such a vigorous antibody response that the hepatitis B surface antigen dissipates quickly, and anything you get is actually IgM. So then the other antibodies to BE antigen, anti-HBe, they come in. So basically, in a small cohort of patients, what happens is that they may get some mutations in the spike protein, which actually codes for the B surface antigen. And they may not produce it or produce it at a very low level, below the detection limit of the assay, and they have DNA at low levels. These particular individuals are known as people who've got occult hepatitis B. Right? So in which scenarios would you see that you don't have hepatitis B surface antigen, but you've got DNA? So you can get that in occult hepatitis B or in the very early phase, this end of acute infection, right? Or at the, obviously, very low levels of DNA in the tail end over here. So we need to be cognizant about occult hepatitis B. So unlike HIV and HCV, the primary HPV serology test used to screen donations is not antibody, it's antigen. So we all know that, right? Like HIV, HPV can be a chronic infection, especially in people who acquire it at a younger age usually. So some percentage of adults can also go into chronicity at up 15 to 20%. In some individuals, hepatitis B surface antigen remains chronically detectable. We call them carriers. And in most infected individuals, it can be a transient marker, which means that it can disappear with the appearance of the antibody. The virus is cleared from the bloodstream, but remains in the liver. And it can, so the cccDNA, the closed circular DNA of the virus, which embeds itself within the hepatocyte site nucleus, will remain there. So these are the patients who can reactivate during immunosuppression. So that's why we generally give prophylaxis for these people who are anti-HBC positive with evidence of past hepatitis B infection. So occult hepatitis B and blood safety. So, there was a lot of misconceptions about occult hepatitis B, that's a defective virus, but that's not the case. So estimates that occult but the dose that 50% of the recipients has been shown to be for acute hepatitis B, 3.2 virions, around 0.64 international unit, but a little quite higher for occult hepatitis B, right? So around 56 international units. So, there's always a risk of it being transmitted, but rare as compared to acute hepatitis B. So, this is just, again, a repeat. So there's an eclipse phase in hepatitis B as well, where the virus is actually multiplying in the liver. That's when nothing can detect it in the blood. And then there's spillover of viremia, right? So in the blood, and then eventually hepatitis B surface comes in. So we've done that. So occult hepatitis B is the most common net yield infection globally for hepatitis B. Some labs screen for anti-hepatitis B core antibody. So sometimes, this can be a Pandora box, because anti-HBC, is it false positive, or is it actually past hepatitis B? So you need to go for anti-HBS and anti-HBE to look for that. So if any of these are positive along with this, so it is past hepatitis B. And sometimes people even vaccinate these isolated core positive individuals to see whether they mount antibody response. So, but these are individuals who can still have occult hepatitis B, right? They can have low levels of hepatitis B DNA, which may be transmissible to the recipient. So NAT testing would protect from occult hepatitis B, but would eliminate too many, anti-core testing could protect from occult hepatitis B, but eliminate too many donors in HPV endemic countries. So this is where NAT comes in. So only a small fraction of anti-HBC reactive donors have occult hepatitis B, right? So why are my NAT and serology results different? So let's discuss that. So if some HIV antibody repeat reactive, NAT not detected. So what are the various scenarios? So it could be a false positive antibody. So when we're talking about false positive, you need to keep in mind the prevalence of the particular infection. That is when the positive and negative predictive values come in. So say you've got a reactive antibody or somebody who's highly unlikely in an area, which is a 0.01 per prevalence. So you really want to confirm with supplemental tests or another assay. So do serological supplemental confirmatory testing. Or it's a true positive serology with low viral load, maybe the blip phase, which we discussed, and maybe the patient is on treatment. And so perform NAT by individual NAT testing. If NAT was originally performed in mini-pool, if NAT is non-reactive in individual donor testing, then perform viral load testing to confirm the lower viral load with a sensitive assay. So if it's a true positive serology with a false negative NAT, when you've tested with another assay and you've come back with a viral load, you would be considering, looking back at your assay in which you did you could go for sequencing. Maybe there's the assay is not picking. This is a rare situation, but I've experienced it on some patients on a particular platform, and it was not so many. Some other labs also came forward for that their treatment naive patients, HIV infected patients, were not being picked up by that particular platform, and the manufacturer they came back and they did a look back and a study and a root cause analysis, and they found out that the particular primers that they were using could not detect that particular variant. So this is really important. Again, if you go back and you look at it in this particular scenario. So in hepatitis C, if hepatitis C antibody is repeatedly reactive, but nucleic acid testing does not detect anything. So it could be somebody who's got resolved infection, or it could be false positive antibody. So you'd be doing, you could test from another assay, do a supplemental test. Previously they were doing REBA, but REBA is quite labor intensive. So usually people use assays from other manufacturers and they confirm from there. It could be a true positive serology with a low viral load. So if it was done on mini-pool, you would do individual donor NAT testing. And then it could be a true positive serology with resolved infection as discussed, or with a false, very rarely a false negative NAT, in which you would be delving into the realm of sequencing to find out. So a person could be HIV or HCV antibody negative with NAT positive. That could be the scenario. So this could be true positive RNA due to window period or acute infection in the donor. And this again varies with the incidence in the donor population. A risk factor interview and follow-up testing of donor can help to determine this. It could be a true positive RNA due to sample contamination, which could be a common thing. Sometimes if proper protocols are not adhered to, likelihood is increased with high prevalence in population and workflow breaches in the lab. Then it could be a false positive RNA to non-specific amplification. Now again, this I have not really encountered that. It is a rare phenomena. You need to use a validated or FDA approved or CE mark test if you're obviously and valid, and you need to, mind you, when we discuss the term validation, validation is done by the manufacturer for these commercial tests. You can verify that. So we need to verify it in the lab and verify that particular. So we should not be encountering this scenario of false positive RNA due to non-specific amplification. And then false negative serology, perform alternative serological tests and or serological confirmation tests. If positive, contact manufacturer for additional investigation. I wouldn't, so when we're discussing false negative serology, so sometimes in the immunosuppressant, I discussed the antibody. So in these special populations, you need to have your be on the alert. So, studies 2 to 20% of the HPC SAG reactive and THBC reactive donors, depending on the lowered limit of detection of the molecular assays. So it also depends on the sensitivity of the assay. So in infected individuals, be detectable if the sample is retested in a larger number of replicates with a highly sensitive test. Confirmed hepatitis B surface antigen in the absence of DNA can also be found in uninfected individuals who recently received the hepatitis B vaccine. About 2 to 3 weeks, it may be there at low levels. It can still be neutralized, mind you, because it is the B surface antigen. So we need to keep our eyes open for that. So if the hepatitis B surface antigen is repeatedly reactive, NAT is not detected. Could it be a false positive surface antigen? Highly unlikely. It could be due to a vaccine. The true positive surface antigen due to vaccine if high. And what about the scenario in which the NAT or nucleic acid test for hepatitis B is positive, but you don't detect the hepatitis B surface antigen? So there are many reasons for this. One of them could be that your assay for B surface antigen is not being able to pick up the B surface antigen because of certain mutation in the spike protein of the virus. So these are diagnostic escape mutants. And then another is the classical occult hepatitis B, low level viremia without hepatitis B surface antigen being detected. So true positive due to sample contamination, it could be that. You can look into it and repeat it. False positive DNA due to non-specific amplification. This is unlikely for HPV target. Repeat testing and or donor follow-up testing may be helpful. And false negative serology, perform alternative serological tests and confirmation tests if positive. You can, feed back to the manufacturer to work upon it. So these are quite unlikely scenarios with validated kits though. So in summary, donor questioning is very important. Many of you must have seen the Swiss cheese model for prevention of COVID, in which there are holes in the cheese. And, the first thing is actually the mask, and then the social distancing, and then avoiding closed spaces, the 3 C's. So you have to do everything, right? It's multimodal. So here, again, it's all multimodal. So it's like the Swiss cheese model for preventing of TTI. So you've got to have robust donor questioning and deferrals accordingly. Then obviously your screening comes into play, your NAT testing, your serology have complementary roles. For HPV, NAT is used to both detect both early and late infection, occult infections. NAT with a sensitive test provides a high degree of coverage for both early infections and occult hepatitis B infections. And NAT actually diminishes the residual risk of transmission of these infections. And I understand that NAT has been rolled out in quite a lot of some centers in Pakistan as well, and it's been being done since the last 5-6 years, and which is phenomenal. And when I actually compare it to the rollout of the SARS-CoV-2 PCR, which has also been phenomenal in a country where, obviously the resources are meager. But we need to move forward with proficiency testing, standardization. And when we talk of NAT standardization, we know we've got the WHO standards, and we're doing IQC, internal quality control, and we need to apply, some kind of Westcard rules on our IQC samples to see where we're going. We could have softwares for that. And then proficiency testing is very important too, an external quality assurance program for this, to actually standardize across the labs. And where there are resource limited settings, where NAT cannot be done. And if they're relying on, RDTs are like substandard, most of them. They're not, they may have false positives, false negatives, but you can always validate some robust RDTs. You can't obviously, in resource limited settings, you have to look at the logistics that in a rural, far flung area, would you be able to do that? But obviously, transport of the samples to consolidated labs where this could be done may be possible with these cards in which the sample is collected, somewhat like DBS, dried blood spots, and having a look at it. But again, with my experience in dried blood testing for IDUs in HCV, I did see a bit of a sensitivity issue there. Sometimes it was like sort of inconclusive or not detected, but detected by proper NAT PCR in the lab. So these things all need to be worked upon and see what's best for a resource limited setting. And I'm sure a lot of work is being done in that. So thank you all for patient listening. If there are any questions, I'm happy to answer.
Thank you, Dr. Sabeen, for a very insightful, for a very comprehensive, and for a very enlightening talk. I think the session itself calls for a day end, and we had a wonderful entire day today, including this session. So thank you, Dr. Sabeen, for sparing our precious time. I am sure and I'm confident the audience have really benefited from the knowledge disseminated by you. I will just take this opportunity to end the session for today, and I would like to thank everyone for joining us today. It was a very comprehensive day, and I wish you all I hope everyone goes and enjoys their day with the family. It is a basically holiday across Pakistan, and so we will resume tomorrow morning fully recharged and with all the energy, so we can absorb all the knowledge that is, and to attend all the sessions tomorrow. So I'll thank everybody for being here and for being with us and for taking out your valuable time to attend these sessions. And thank you once again, Dr. Sabeen. I will be calling this session off today. And thank you, and Allah Hafiz, everyone.